Good day, dear students. Today we will have a lecture about computed tomography. We'll discuss some technical moments, definition of computed tomography, some few words about history, and of course about clinical application of this method. So we'll start with definition. Computed tomography is a method of non-destructive, layer-by-layer study of the internal structure of a person or a man's body based on the measurement and computer processing of the difference in the attenuation of X-ray radiation by tissues of different density. Lots of words in this definition, but I'll give you some main points that I think. The main point is that it's based on X-ray, like CR, like radiography, and of course it's based on computer processing. So what is method principle? Method principle is scanning an object with a thin X-ray beam while the table is moving. We talk about modern computed tomography, registration of attenuated radiation, then reconstruction of the tomographic layer, building a 2D half-tone image, and then multiplanar or 3D reconstructions. So computed tomography is a special type of X-ray procedure that involves the indirect measurement of the weakening or attenuation of rays in numerous positions located around the patient being investigated, being examined. Most CT slices are oriented vertical to the body in perpendicular plane, so-called axial plane. Some words about history of CT. The invention of computed tomography was made by Sir Godfrey Hounsfield in early 1970s. He was an English engineer and was considered by many to represent the greatest step forward in radiology since the discovery of the X-rays. Together with Alan Cormack, Hounsfield was awarded the Nobel Prize in 1979 for his achievement. The first CT scanners were designed for head studies only, but soon whole-body scanners became available as well. Today, CT scanning can be used for imaging of course, any part of the body. The first patient brain CT scan was done on 1st October 1979. At this picture, you can see Sir Godfrey Hounsfield with the first clinical CT scanner, EMI 1000, in 1972. There are some generations of CT machines, of CT scanners. First was rotatable, rotary, translatable with one detector, then rotary cast with multiple detectors, third rotary with moving detectors, and fourth rotary with fixed detectors. Conventional CT, single slice CT, you can see principle at the left picture, obtains image data one slice at a time. The patient holds his or her breath, a slice is taken, the patient breathes, the table moves, and the sequence is repeated. This technique requires at least 2 to 3 times the total scanning time of helical CT for any given patient scan volume, making optimization of scanning during maximum contrast more difficult. Minor changes in lung volume, for example, with each breath hold, may make substantial changes in the chest and abdominal anatomy scanned, resulting in skip areas. More recent conventional scanners can simulate helical scanning by cluster technique. Several sequential scans are obtained during a single breath hold. At another hand, helical CT, also called spiral CT, at the second figure, is performed by moving the patient table at a constant speed through the CT gantry. Gantry is a hole in this scanner, while scanning continuously with an X-ray tube rotating around the patient. A continuous volume of image data is acquired during a single breath hold. This technique dramatically improves the speed of image acquisition, enables scanning during optimal contrast opacification, and eliminates artifacts and errors caused by misregistration and variations in patient breathing. One of the advantages of the helical technique is that lesions smaller than the conventional thickness of a slice can be detected. Small liver metastases, for example, will be missed if inconsistent depth of respiration results in them not being included in the section. So, multi-detector helical CT is a major technical advance in CT imaging, utilizing the principles of the helical scanning, but incorporating multiple rows of detector rings. This technique allows acquisition of multiple slices per tube rotation, increasing the area of the patient that can be covered in a given time by X-ray beam. Available systems have moved quickly from 2 slices to, I think, 380 slices and more, which covers more than 1060 millimeters of patient length, for which 1 second or less rotation of the tube. So these are photos of modern CT at the right picture, and one of the first clinical CT scanners in the left. You can see how small was the screen, how old was this technique, and these are examples of pictures of medical images that were made by these machines. At the left you can see head, you can see brain. This picture had lots of artifacts. Quality of this image and resolution was very bad, and you hardly could differentiate between bones and white matter or gray matter. And at the right, this is a modern technique. This is angiography. I think the whole body angiography made at the modern CT scanner. You can see that contrast enhanced images were made for aorta, for thoracic aorta, for abdominal aorta, for abdominal branches, and for legs. These are examples of an old, not so old, I think, at the end of the 20th century, CT coronarography, and how it's noisy, how it's difficult to differentiate between normal and pathology, and modern 5 or 6 years old image with arteriovenous fistula of coronary artery, and how it can be simple differentiated from normal. Of course, you can see it in the by the arrow. So density in Hounsfield units. What is density? Modern equipment has a capacity of more than 4,000 gray-tones, which represent different density levels in Hounsfield units. The density of water was arbitrarily set at 0 Hounsfield unit, and that of air at minus 1,000 Hounsfield unit. So different tissues has their specific Hounsfield units, more high density has compact bone, but parenchymal organs have, I think, the same density, about 50 Hounsfield units. But the monitor can display maximum 256 gray-tones. However, the human eye is able to discriminate only approximately 20. Since the densities of human tissues extend over the fairly narrow range of the total spectrum, it is possible to select a window setting to represent the density of the tissue of interest. The mean density level of the window should be set as close as possible to the density level of the tissue to be examined. The lung, with its high air content, is best examined at low Hounsfield unit window setting, whereas bones require an adjustment to high levels. The width of the window influences the contrast of the images. The narrower the window, the greater the contrast, since the 20 gray-tones cover only a small scale of densities. So, electronic window is a part of the Hounsfield scale which corresponds to the difference in the brightness of the screen from white to black. Window width is the value of the difference between the largest and the smallest values of density of attenuation coefficient displayed by a given brightness difference from black to white. And window level is the value of the attenuation coefficient density corresponding to the middle of the window. So I can illustrate this thesis with this examination, this pulmonary CT. This is mediastinal or soft tissue electronic window, and we can differentiate fat tissue and muscles and mediastinal structures, but we can hardly differentiate lung structures because their density is much more lower than window width. So we change this electronic window to thoracic, to pulmonary, and we can see that there are pathological findings in the right lower lobe. There is pneumonia, but we can't differentiate soft tissue structures. And these are two main electronic windows, density windows, pulmonary and mediastinal. And the third basic electronic window is bone window. It's used for analyzing bone structures. So what we should discuss about CT, of course, is radiation exposure dose. So CT is a technique that gives a relatively high dose of radiation exposure. For example, in late 90s in UK, CT had only 2% of all examines, but 20% of total dosage. And in 90s, it was 4% of all examines and 40% of total beam. So we should have in mind these facts while referring patient to CT. I think doctors of all specialties should know this, and of course we are radiologists should think about it while making CT. So reducing radiation dose is desirable when possible, but it generally results in decrease in image quality because of increased noise. CT radiation dose may be reduced to some degree by increasing gantry rotation time, pitch or slice thickness, by special scans, or by using other more complicated techniques, for example, artificial intelligence. However, the term low-dose CT usually implies the use of reduced tube current or something in the kilovolt peak. Low-dose CT, low-dose pulmonary CT is usually used for children, for screening patients, we will discuss it, or if multiple follow-up examinations are necessary. CT lungs, we'll talk about CT lung screening, I think, later. So this is an excellent, beautiful example of reduction of radiation. It's CT coronography made with exposure only 0.6 millisievert, and this high quality is possible because of using of artificial intelligence. Primary picture was very noisy, but this noise was decreased by artificial intelligence. So you can see that this picture is a very smooth. And of course, we should use this artificial intelligence, this so-called iterative reconstruction, to decrease radiation dose. Another point that we should discuss is contrasting in CT. Intravenous iodine-based contrast agents are administered in CT to enhance density differences between lesions and surrounding parenchyma, to demonstrate vascular anatomy and vessel patency, and to characterize lesions by their patterns of contrast enhancement. Optimal use of intravenous contrast depends upon the anatomy, physiology, and pathology of the organ of interest. For example, in the brain, the normal blood-brain barrier of tight neural capillary endothelial junctions prevents excess of contrast into the neural extravascular space. Defects in the blood-brain barrier associated with tumors, stroke, infection, and other lesions enable contrast accumulation within abnormal tissue, improving its visibility. In non-neural tissues, the capillary endothelium has loose junctions, enabling free access of contrast into the extravascular space. Contrast administration and timing of CT scanning must be carefully planned to optimize difference in enhancement patterns between lesions and normal tissues. So it's mandatory for tumors of any localization, of study of blood vessels, etc. Of course, it has some contraindications because it's medicals, we often use this item is syringe injector, automatic syringe injector. It has two bulbs. In the first we fill with contrast media, second with soling solution, and it has some, of course, advantages in comparison to manually injection. It has constant speed, about 4 or 5 or more milliliters per second. This is an example of effectiveness of using this contrast enhancement. This patient with dyspnea, with cough, we can find a triangle formed zone in the left lower lobe. This zone of consolidation, non-airfield zone, and we can differentiate between numerous pathologies, for example, pneumonia, abscess, tumor, and so on. But when the injected contrast media, we can find lone thrombus in main pulmonary trunk and main pulmonary arteries. This is pulmonary embolism. And so this condition can be found only by CT with contrast enhancement, CT angiography. In abdominal CT, we make numerous phases. So this examination is called multi-phase CT, multi-phase abdominal CT. First native before the injection of contrast agent, then arterial. After 20 seconds, we can see that aorta, aortal branches are filled with contrast media. Then venous, density in veins is maximal, and the last delayed phase. According to patterns of contrasting of lesions, we can differentiate between malignant and non-malignant lesions. For example, this is proved hepatocellular cancer, carcinoma, a big lesion in the left hepatic lobe. So we can see that it is hypodense at the first native phase. Then it has a extremely high density, non-homogeneous high density. It's hyperdense at arterial phase. Then there is a washout effect, so it becomes hyperdense at delayed phase. So we can be sure that it is hepatocellular carcinoma, and there is no need for making biopsy for this patient, because this pattern of contrasting is very specific. I can show you some clinical examples of effectiveness of using CT. At this example, you can see brain CT, and there is a big zone, hyperdense zone, in the left hemisphere, in the left temporal lobe. This is post-traumatic encephalomalacia, post-traumatic liquid-filled area, and at the reconstruction, volume rendering reconstruction of skull, you can see post-surgery changes. post-surgery metal objects, and a big defect in the temporal and frontal bones. So I can comment what is volume rendering reformation. Volume rendering technique is the term applied to a complex procedure that is very versatile and can combine characteristics of surface rendering and maximum intensivity projection. This technique assigns a range of capacity values of CT numbers and thus yields better definition of objects, contours, or semi-transparent display of structures. Volume rendering technique is quickly becoming an established standard technique for rendering of spiral CT or multi-slice CT datasets. Image quality is high and the user has a whole range of rendering effects at his disposal. Volume rendering can be used for CT angiography, for skeletal imaging, tracheobronchial imaging, for vertical colonoscopy. It displays lungs, abdominal organ, and even as primary tool for image analysis. Of course, it's very beautiful and very informative to see this reconstruction in comparison to planar images. Some words about special techniques, CT perfusion. What is CT perfusion? Is imaging a specific form of CT. It allows to assess flow through blood vessels with injection of contrast agent. So blood flow, blood transit time, and organ blood volume can all be calculated with reasonable sensitivity and specificity. This type of CT can be used for the heart and, of course, for the brain. For the brain, CT perfusion imaging can often detect poor brain perfusion well before it is detected using a conventional spiral CT scan. This is better mainly for stroke diagnosis than other CT types. So at the left you can see normal brain image, but in the right you can see that mean transit time is high at the right basal ganglia. So these are early signs of ischemic stroke. At late time, I think at 6 or more hours after a stroke, of course, we can use routine CT. And in the left, you can see a big hypodense zone in right hemisphere. This is ischemic stroke, and in the right, you can see hypodense zone in the left basal ganglion. This is hemorrhagic stroke. Hemorrhagic stroke can be differentiated effectively in early stage of the disease in comparison to ischemic stroke. So CT is good in detecting changes, of course, in ischemic stroke over time. Firstly, we can see nothing, then hypodense zone, then it can be hemorrhagically transformated, and in months or years we can find a liquid filled area. This is another example of effectiveness of CT perfusion in stroke. In the left temporal lobe, there is no changes at routine CT, but there is a great change in Tmax. Tmax is a time of while contrasting will be maximal. And I'll show you some other pictures. For example, effectiveness of using CT in pulmonary pulmonology. In this patient, we can find some subtle changes in the left lower lobe at radiography, but lots of changes at CT. There are lots of nodules in the left lung. These nodules are connected with tuberculosis. So, of course, CT is much more informative for tuberculosis diagnosis. So we can talk about activity of this process. We can say what form of tuberculosis is, and so on. Much more information. For children, we can find not only diseases, but these anatomical anomalies like sequestration. This is intralobar sequestration of right lower lobe. You can find cystic zone in the right lower lobe that is not connected with tracheobronchial tree, but it feeds by anomalous vessel from aorta. This is an example of abdominal multiphase CT. So you can find out big lesion in the right hepatic lobe. It looks terrible, and without contrast enhancement you can say anything about it. Is it malignant or not? But this pattern of contrasting, this feeling, this so-called centropetal contrasting, is very specific for hemangioma. Hemangioma is a non-malignant lesion that I think 10% of our population has the same lesion. CT in angiography, in angiosurgery, of course, it's a very important method. We used it for before aortal surgery, like this example, patient with a big thoracic aorta aneurysm. We can find lots of thrombus, we can find true lumen, and we can find dissection of wall. So without contrast enhancement, we can't find it anymore. Modern use of CT coronary angiography. This is a patient with bypasses after cardiac surgery. So we can say block there or not, and this is a non-invasive procedure. So we can make examination, and we can make these beautiful volume rendering 3D reconstructions. So it's very good for surgeon to analyze his work by this method. CT can be used for as a screening method because fluorography and radiography are ineffective in detecting lung cancer at an early stage. There are some world clinical trials, they're called Nelson and NLCT. For example, in the United States, they have shown that deaths in a group of CT fell from 443 to 346 it was made because of CT useness. In Moscow, there were a pilot project, experiment, a trial of using this method for screening. Only a risk group, it's men at an age over 50 years and long term of smoking. So it was a special algorithm what to do with a patient. We can find some nodules depending on size, on margins, shape of this nodule. There is a scheme what to do. To do nothing, to do follow-up, or to do biopsy or surgery. It's very effective for early detection of lung cancer. Some words about another method, cone beam CT. I think it's called CT, but it's not CT in radiology. It's another method. Patient is staying and it is rotating around his head. It's used only in dentistry. It has small radiation dose and used for only maxillofacial area. So you can find teeth, you can find alveolar process, but nothing about other areas or organisms. And at the end, I will show you non-medical effect of use of CT. In British Museum, they use CT for mummy investigation because CT is a good method of non-destroying visualization. They were not unpacking mummy, but made these beautiful images of what in it, about body, about some artifacts, and so on. So CT can be used for these non-medical purpose. Thank you for your attention.